Hello, I'm Stephen Bradford. I'm living in Alabama in the Mobile area. I work in a steel mill, and I learned in January that I was diagnosed with stage 4 non-small lung cell cancer. In January, I was just visiting my primary care doctor for just a checkup and get my prescriptions recertified and reauthorized. And during that checkup, the doctor noticed a lump on my left side clavicle area, and that led to a chest X-ray, and then led to a CT scan. So I wasn't feeling any type of pains, wasn't having any coughs, and it was just kind of a shock. And of course, here I am going to start researching what was being said, which led to some information that I was still waiting on a diagnosis, but now I've had some information that I've gathered, which was, kind of interesting but depressing. On my first meeting with my oncologist, he said, so they've done a tissue sample. So they have learned that you do have stage 4 endocarcinoma. And he was discussing with me that it's not curable, but it's treatable, and that we would be trying to send off some tissue and blood for some biomarker testing. Said it was important to try to find maybe a targetable treatment for me. Otherwise, I probably was looking at 2 to 3 years on the scheme of things. So we were pretty interested. And of course, I left there researching biomarkers and what they may lead to.
So Lynette, Louise, thanks again for joining me. It's always really powerful to hear a patient in their own words and what their experience has been. And so, want to spend a couple minutes just talking about the kind of on the provider side of how can we better support patients? Maybe I'll ask you, Lynette, on the pathology side of things, like kind of turnaround times, and how do you think about turnaround times as a pathologist? Because I'm sure every clinician is saying, I want this as fast as possible. And what are those rate limiting steps on the pathology side?
Yeah, sure. So, I think there's obviously two strategies. There's a tissue-based testing strategy, and then there's a liquid-based testing strategy. If we start with the tissue-based testing strategy, there's a number of checkpoints, right? So the biopsy has to be obtained, it has to be processed. You have to confirm you have adequate tissue and adequate tumor in that specimen. And then there's the process of actually receiving an order or triggering an order. And obviously the environment in which this happened varies tremendously from place to place. In some institutions, you may have reflexive orders that emanate out of pathology, and that can speed up the process of getting more information. In other settings, and a lot of this can be very much driven by the cost environment and what is considered to be acceptable practice for pathologists to test that pathologists are permitted to order versus what needs to come from a treating clinician, et cetera. So a lot of variables there. But I think ideally you have a scenario where diagnosis is made, reflexive testing is initiated, and that's your mechanism to kind of get to an answer as quickly as possible with biomarker testing. For tissue in general, we're typically looking at somewhere in the order of 1 to 2 weeks for a comprehensive genomic profiling assay. It's probably closer to 2 weeks, especially if it needs to be sent out. There are other test types that are a little bit more focused, but can deliver some more focused information quite quickly, as in the order of a couple of days. I think we're increasingly moving to a place where there's a bit of a staged approach to biomarker testing, where you may have a very focused assay that can deliver results in, say, 1 or 2 days, followed by a reflex or kind of consistent usage of a more comprehensive panel to deliver more information that's going to give you a little bit more depth and hopefully cover any targets that are missed in that more focused assay. So on the tissue testing side, I think you're looking anywhere from a few days to a few weeks for an answer. And then on the liquid side, obviously that loops out the whole process of getting the biopsy and getting the path review and getting the order in for tissue testing. So we know we can cut down turnaround time to 7 days or less for liquid biopsy-based analysis. The challenge there is just sensitivity. And if you have a tumor that's not shedding as readily into the bloodstream, you may miss the key biomarker alterations from liquid testing alone. So we're often looking at opportunity to pair the two of them to optimize the likelihood of finding a targetable biomarker.
Great. And I would say in my own practice, I typically, will tell patients those timelines and usually try to touch base at least weekly, so that they're constantly seeing that we're thinking about them and they're not on an island. And so maybe we'll move on to our next clip and that'll be another springboard for discussion.
I was looking at starting chemo, and I actually did have one chemo treatment, not the full treatment, just one session. And then before my next, it was every 3 weeks. So at the end of that 3 weeks, before my next treatment was going to be, we found out that I did have this NTRK fusion, which we stopped the chemo and started looking forward to starting a targeted therapy. It was almost like me and my oncologist were learning this for the first time. He wasn't really up to date on my specific biomarker and what my therapy would be, and it was kind of like we're excited to start it, but we were also both looking for information. So I left out of the office, kind of wondering how this might go. So I started, of course, trying to research it for myself, how the different therapies would work for me, and was finding out that in some cases it was very, very good results.
So, Luis, how do you educate? Like, what are some of the challenges that you encounter in educating patients about these rare biomarkers like NTRK?
I mean, something very important is that they understand that we spend some time hoping to get the NGS results because we are able to identify a number of subtypes of lung cancer from which we not only have personalized treatment, but very precise treatments. And among those, there are some very exceptional cases, very rare cases, but it is very important to recognize them because we really have very good treatment for them. The outcome is somehow very differently, and particularly the treatment is very different as compared to the standard of care chemo-IO. If we like to really benefit those patients, we really need to understand that very well. Because of the type of treatment we're going to deliver here with a specific type of side effect profile, I think it's very important for them to understand. I tend to spend some time somehow anticipating the potential side effects, how to manage those side effects, including the fact that we may have to dose reduce at some point, which type of therapies may help. And in fact, at some point, we will have still more treatments down the road. And that is another important message here, that this is not going to finish with the first-line therapy. We have another type of opportunities down the road, and I think that's very important to educate on.
That's great. And Lynette, we see marked heterogeneity in reports, right? Molecular reports. Some are very prescriptive and even put therapies next to them. Others just report the alterations. For our community oncologists who are treating many, many different types of cancers, like, what are the challenges in educating our clinical partners about some of these rare biomarkers?
Yeah, the reporting is a really interesting challenge, I think, for laboratories and for consumption by the providers. You have to strike a balance between making sure that you're providing the critical information about what is a targetable biomarker, but not going overboard and positing that everything that you identify in the cancer is ultimately going to lead to a potential therapeutic option. So I think it's this very interesting kind of balance that you need to strike. we have tended to rely heavily on guidelines that point to specific genes as being associated with, say, in the United States, FDA approved drugs, and making sure that those particular correlations between a gene, a known type of alteration in the gene, and the appropriate drug, that those sort of pairings are brought up to the very top of the report. So you can quickly glance at it and say, okay, I have an EGFR mutation. I know there's an approval for EGFR mutated lung adenocarcinomas. We can move on. And then what do you do with the other 26 alterations that maybe you found? And maybe a few of those will point to an opportunity for a clinical trial at some point in the future. And maybe you can call that out, but you really have to figure out how to differentiate between those immediately actionable things and the things you might want to pull out of your back pocket when the time comes as you're thinking about additional clinical trial options. So I think that's really the task for laboratories, to figure out how to strike that balance correctly. And then I think from the standpoint of providers and care institutions, putting forth forums in which people can have a conversation about the results on these reports, molecular tumor boards, really, I think, a critical a place where these types of conversations can be had. So really trying to resource institutions to provide that opportunity for their oncologists and other care providers, I think, is critical.
That's really, really helpful. And so now we're going to move back to hear from Stephen one more time, and that will give us an impetus to our last question discussion.
Well, when I first started the targeted therapy, I was having some pretty good side effects in the beginning with muscle pains, and it seemed like each day it might be in a different area. And I was actually using compression socks and some massage machines it mainly was affecting me in the evening time. And that seemed to last about 2.5 weeks, and they kind of just went away. And then after that it happened, I did start having lightheadedness, dizzy spells, and also had a few occurrences of passing out, which led to me stopping my blood pressure medicines. So after that, I haven't passed out again, and I still get a little lightheaded, but it's manageable.
So I think Stephen's case really illustrates some of the issues that people can encounter, particularly early on with TRK inhibitors. So Luis, how you already alluded to it in the last discussion, but perhaps you could expand. How do you prepare for patients for some of these side effects, and what's your typical frequency of follow-ups, especially at the beginning for your patients?
Okay, so during the time I'm waiting for the NGS results and maybe the initial interviews with the patient, I tend to somehow prepare for the general approach for targeted treatment. Then when I know that this patient is having specifically an NTRK-driven lung cancer, I'm going to go through the expected outcome, response, and so on. And I tend to, at the time I'm explaining about the side effects, I tend to emphasize that we are hoping or we're expecting the tumor to shrink at the same time, so that it's getting, for that very reason, I'm typically asking for a CT scan in 4 weeks. So, because this is when I'm expecting the initial, let's say, peak of side effects. And I really like to bring to my patient some good news about how the treatment is going. I typically see my patients like every second week for the initial 6 weeks. If my patient, I see something is wrong, I may give it a call on the week in the middle between every 15 days. And, I tend to anticipate mainly the more frequent side effects that have been here reviewed. And, if things are not working, and particularly if dizziness is being strong and so on, I may consider to dose reduce if needed.
Yeah, my practice is very similar to yours, which is, I also see patients every 2 weeks at the beginning. I think virtual care has also made it easier for some of those visits on the off weeks where you can just have a quick video and check in on things. And I also get an early scan. I usually go in that 6-week range, but you're right. It's really helpful to show people early on, and these drugs work really, really fast, right? Where we can typically expect to see a response at the time of that first scan.